What's happened at ESTRO in the breast here? What's really got you excited?
Let's say the first thing what I was involved already for a long time ago was the introduction of breast conserving therapy. So, and I'm very fortunate I could lead a couple of trials in breast conserving therapy. First, show that results with mastectomy for breast conserving were similar in terms of survival. And then second, we showed that with higher radiation dose, with giving a boost, that you reduce local recurrence in breast cancer with a factor of 2, and so that's important. But then what we learned is that young patients with breast cancer do worse. And we tried to explain, and we looked to our database, which considered more than 5,000 patients who were randomized in the boost first no boost trial, what the explanation is on why do the young patients worse, and also what are the consequences. So we looked into detail, we looked at histology, we looked at clinical features, tumor size, lymph node metastasis. We could not very well explain that. But nowadays, with the most recent analysis that I presented here, we think there are two factors. One, the young patients have more high-grade tumors, and second is that probably they have more DCAS, so microscopic disease around, let's say, the tumor bed. So we compared, for example, the MRI. If you have the MRI, let's say this tumor size, then we looked at pathology, what's around that tumor size that you see on MRI, and we found much more microscopic tumor sites and, let's say, amount of tumor cells and tumor cell density. And so we think that, let's say, the worse results in young patients are properly explained to more tumor elsewhere in the breast, or the breast is, let's say, pre-malignant.
So why isn't the radiation tackling those microscopic deposits?
So what we do, and what I could show yesterday on this meeting, is that just this group of patients with high grade and microscopic ductal carcinoma site around, that if you give a boost, that you do much better. So we developed a nomogram, and each individual doctor can see for his patients what will happen whether if you give adjuvant chemotherapy or tamoxifen or a boost dose and you have DCS, you can really predict this patient has, for example, a 20% high chance on local recurrence, and then what you can add and what you should do better. So the next step is what we are busy now in Amsterdam, is to characterize more the gene profiles. What is the difference between the old and young patients? And soon, within 1 or 2 years, we really hope to show which patients, let's say, are worse off with breast conserving therapy based upon the gene profile.
I mean, presumably you looked at triple negative and that sort of thing. There's nothing there at all.
No. We know, for example, that triple negative do worse, but that's, of course, they have high grade, so that's similar.
It's
and
same sort of thing.
similar. And let's say with luminal A do better. That we have seen and demonstrated. Also, we showed with the wound profile, if you have an activated wound profile, you do worse. But still, that's not enough for an individual patient with, say, with high chance. So that we're working on.
Next step.
The next step, what we are busy now with radiotherapy, and certainly in Amsterdam, is that we do much better with image-guided radiotherapy. You know, we have developed, let's say, the imaging device that you could see during radiotherapy, how the patient is treated. We come to a much more precise, focused radiotherapy. So, and then we decided, instead of waiting after the surgery to treat the patients, now we do it on beforehand. And the advantage is now with the cone beam CT scans that we make on the linear accelerator, we see the tumor very well located, so we can focus on the tumor itself and then deliver a high radiation dose. And thereafter you do surgery.
Right.
Because nowadays all these partial breast stories is the surgeon removes it. In 95%, I would say, the tumor is at the border of the specimen, so you don't know where, let's say, the margins are minimal and where it's extensive, and where the tumor was, because it's all put together, and so now we know much better. And apart from that, is we got fresh tumor material. We see the changes in gene profile or the proteomics, so we can predict which patients is sensitive for, let's say, radiotherapy and not, or for the drugs that are involved.
And you're doing this in a cohort?
Yes, this is
a
a joint trial that I set up. You mentioned that I was professor in Paris and set together as in Amsterdam. So I have a link with Institute Gustave Roussy, Amsterdam, and Karolinska in Stockholm. With the three of us, we do now this trial.
And now you have a Dutchman in running Gustave Roussy, so with Lex Eggerman there.
So that will stimulate further the cooperation. So that's, you see the Dutch mafia is extending. That's good.
Harry, thank you very much indeed. That's just go.
Can I tell you some of my work?
Go for it.
I would like to tell you one of my worries I have now at the present time. You know, at the ASCO, the CLCB study has published and showing that, let's say, giving hormonal adjuvant treatment instead of radiotherapy has produced extremely good results. We have this target trial, probably you have discussed that before. What are all these trials are let's say, suggesting that you can do with different things than radiotherapy or different approaches in a very easy, rapid way to deliver, or with the long-term hormonal treatment you can get the same results. But I would warn the community that they should not, let's say, jump on these results. We should be extremely careful, because you should look at the selection criteria of the trial, and I think what is more important, that we as radiation community should investigate much more in depth which patients need radiotherapy and which patients don't need radiotherapy, and immediately replace them with hormonal therapy like aromatase inhibitors. That's the wrong way, I think, to go, because you know very well the side effects of aromatase inhibitors. If you take them for 5 years, you got problems with the wrist, you got some muscular problems, you got a high chance on bone fracture, etc. Instead of a simple treatment of radiotherapy for 3 weeks. And I mentioned before now the image-guided radiotherapy. That's completely different than the radiotherapy in the past, because nowadays we are much better to spare the heart, to spare the normal tissues. And so the side effects that we know from the previous trials with bad radiotherapy are not, let's say, existing anymore in the future. So I think, let's say, for all the patients, instead of 5 years of treatment with drugs with side effects, compared to the 3 weeks of treatment, it's much easier treatment, and all the patients are much better off. And you are sure that the dose is delivered.
Be done. And are there plans to do that in Europe?
Yeah, it is. I can refer, for example, to a simple trial in Denmark, the SOL trial, where they try now to extend it after 5 years to continue, but mostly all the patients stop at 5 years because they are fed up with the side effects.
Or because 5 years was the tamoxifen time and doctors just took 5 years, because that's what they always did. So.
Yeah. But it's mostly the patients that stop.
I share your concern, particularly about the length of follow-up of some of these trials, and the selection criteria are clearly very confused, at least as I see them in the Target paper. I also, however, I'm a little bit concerned with the image-guided radiosurgery technologies which are evidenced in this meeting. And I'm not seeing too many randomized trials comparing the knives with the conventional radiation. Does this bother you, or is this just because I don't understand the physics?
Let's say, for example, the lung trial of lung patients. We do now a trial in Holland to do the stereotactic irradiation versus surgery. Okay. So these are small tumors in the lung, and despite the fact that we shown, for example, in our institute, that with this group of patients with T1, T2 tumors, small tumors, we give only in 3 sessions, so 3 times very high radiation dose. Yeah. And then we have seen, let's say, local control in 90 to 95% of the patients. And that's in the phase 2 study, but now it is translated in a phase 3 study where we compare, let's say, surgery, so tumorectomy, I would say, versus radiotherapy. And so that's going on. But if you look at the phase 2 data of the lung trials, it's absolutely convincing, because there's no morbidity. You don't have to go to the operation theater. No post-operative.
And all these knives are the same?
Absolutely not. It really needs very dedicated, very sophisticated radiotherapy. Yes. And you have to take care of the movement. You have to calculate precisely. You have to image it precisely, etc. So it's not an easy job. So
will we know in 2 years' time at ESTRO 31, for instance, that
it will take 3 to 4 years.
Longer than that.
Yeah. Yeah.
Okay. Harry, I can rely on you to do evidence-based clinical trials forever. Thanks very much.
Thanks. Okay.